You're listening to Medscape's In Discussion series on myelofibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Tania Jain. Dr. Jain is an associate professor of oncology at the Johns Hopkins University School of Medicine, where myeloproliferative neoplasms are the focus of her research. And she is also the director of the Adult CAR T-cell therapy program for hematological malignancies at the Sidney Kimmel Comprehensive Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, everyone. I'm Tania Jain, and welcome to episode number 6, which is the concluding episode of season 1 of the Medscape In Discussion podcast series on myelofibrosis. Today, for our final episode, we are discussing the future directions of myelofibrosis research with our guest, Dr. Gabriela Hobbs, who is a hematology-oncology physician at Mass General Hospital and specializes in MPNs, chronic myeloid leukemia, and acute leukemias. She's an active clinical researcher, leads the MPN research program at Mass Gen, and has led several clinical trials and translational research for MPN in her role. So welcome to the Medscape in Discussion podcast, Dr. Hobbs.
Thank you so much for having me.
Wonderful. So we saved the best discussion for the last, and over the course of this podcast, we've talked about a lot of things. We've touched on prognostic scoring systems. We've talked about the current landscape of treatment. We've talked about some of the clinical trials or drugs that are in the pipeline and may seem promising. What we wanted to talk about today was, what does the future look like, and what's worth looking for in the future for myelofibrosis. I was thinking we could focus a little bit on non-drug related research that is probably needed at this time to move the field forward. What do you think about that, Dr. Hobbs?
Sounds like a good topic of discussion with lots to say.
I know, right? We could obviously easily go astray here, so we'll try to bucket ourselves in some subgroups here. Maybe we'll start with prognostic models. We have a nice alphabet soup that exists, and Dr. Vachani went over the prognostic models in nice detail in our first episode. But it also makes me think and wonder, how do you use the prognostic models, and how do you think they're limiting, and what we can do to perhaps improve, or what we should be thinking about in terms of investigating that would improve the use of prognostic models in the future?
Yeah, great question. So, I mean, on the one hand, I think it's great that we have a lot of scores because that to me indicates a lot of progress in the field. If you look at the original scores, we've come a long way since then. And, initially the scores included mostly clinical variables, whereas now the newer scores, like the MIPS and the GIPS, they rely much more heavily on molecular markers, which we know really are the main drivers of disease prognosis. And so having a lot of scores is not a bad thing. It's just thinking about how do we use these scores. So just to answer that main question, I would say that in clinical practice, I tend to use the more clinically focused scores like the DIPS plus when I first meet a patient. And then when I have more of their information, I usually use the MIPS 70 version 2 and occasionally can kind of like double check that with the GIPS, which is primarily a mutational based score. In addition to being able to really risk stratify patients, I do think that these scores are missing some important information. And that is, how do we incorporate how patients respond or don't respond to treatment? And can we use those scores to do more than to just tell a patient you have high risk disease or you have not high risk disease? Like, for example, we have a score that's been validated to look at how patients will do post transplant. And although that's useful to think about, how is this patient going to do after they have a transplant? I think one of the most difficult discussions that I have in clinic with my patients is after I use any of the risk scores, and either by DIPS plus, they're intermediate 2 or greater, or in the MIP 70 score, they're in the higher risk groups, and I say, okay, you need a transplant. We're still measuring the survival of patients with myelofibrosis in the order of years. And so therefore, knowing when is the sweet spot time to take him to transplant is actually really difficult. And I think if we were to have a score, for example, that were to say, this person needs a transplant within the next 6 months or within a year to 3 years or after that, man, that would make our discussions in clinic so much easier, and we could really guide our patients better. Sometimes, I don't know about you, Dr. Jane, but I find myself having these discussions with patients, sometimes over the course of years, saying like, "Yes, you will need a transplant. I just don't know when because everything looks stable, even if your risk score looks like a high risk score on paper."
Yeah, absolutely. And then what I struggle with sometimes, and hopefully some of the drugs will change that, but what I struggle with right now is the big spleens and how they may be lower risk on the prognostic model, which does not include spleen anywhere, and they have this large spleen that at least our transplant studies show that usually don't do well with transplant. How do you end up incorporating, like, what do you think about evaluating the spleen size into prognostication, which is not included in the current prognostic models?
Yeah, what a great question. I mean, I think that for patients that were getting started on treatment and for patients that we are getting ready for transplant, we all know that if that patient comes to see you with a big spleen and they don't respond to their therapy, it makes us nervous to think about sending a patient to transplant with a massive spleen. I think we worry about engraftment and prolonged cytopenias and poor transplant outcomes. And it's fascinating that none of the many scores that we have incorporate that. I think that the one example I've seen of incorporating the spleen response is the RR6 model that basically looked at after certain periods of time, like 6 months, what dose of ruxolitinib was a patient on? Did they have a spleen response? And are they transfusion dependent? And that helps to, predict patients that have better or worse outcomes. And those types of scores I think are really what are needed to help us not just make that decision of yes, you need a transplant or no, you don't need a transplant, but is this a person that I need to switch from ruxolitinib to something else? Or in the near future, when we have combination therapies, if a patient is high risk on their RR6, do I need to switch course and add another drug, send it to transplant sooner, et cetera? So I think that's really what we need, scores that are more functional.
Absolutely. I think those evaluations, those correlations will be very important to see how people do. If they're not responding to ruxolitinib, is transplant the next step, or is adding another drug or changing the JAK inhibitor the next step?
Yeah, absolutely.
Speaking of more drugs being FDA approved, which is a good thing to have, and we have always suffered from this poverty of not having drugs available in terms of options. So now that we have four JAK inhibitors available and hopefully some other non-JAK inhibitor medications available in the future, I think one of the questions that we'll need to address in the future will be, who is the patient who is most suited for an X drug or an X combination? What would you like to see to be investigated in terms of biomarkers of response with these available strategies?
Oh, I would like to see biomarkers that predict response. First of all, I think that, it's interesting. You look at all of these studies and basically they are all measured the same way. Whether it's a JAK inhibitor by itself or it's a combination therapy, the endpoints are all the same endpoints. They want to make sure that a patient has an improvement in spleen volume response, which of course you and I were just talking about. We all share about spleen volumes, and they all want to see an improvement in symptoms. And although, of course, from a patient perspective and a physician perspective, we want to treat our patients to make them feel better. Honestly, we want to do more than that. And especially if we're going to ask our patients and our payers to approve and take two drugs at the same time, we need to start asking for more meaningful endpoints so that we can sit with our patient in clinic and have a real discussion of why am I going to subject my patient to two side effect profiles, two different drugs, two copays, and all of that if I don't really know who is going to benefit from those two drugs and who isn't. And so I would like to see subgroups starting to emerge from these combinations and to say, patients that have this mutational profile or patients that are anemic or patients that have, refractory splenomegaly, et cetera, respond better to this, that, or the other drug. And so far, I think that it's just a difficult disease to study, and I think that the different companies that are out there trying to find a successful combination have been trying to look at a variety of biomarkers. It's just nothing has emerged as a slam dunk. We have changes in fibrosis in the bone marrow at different time points. We have changes in variant allele fraction at different time points, changes in cytokines, changes in how many CD34 circulating cells we have. So I think that the fact that we don't have a slam dunk biomarker to predict response to different therapies is not for lack of trying. And I hope that, when you and I have this discussion in the next couple of years, we can start talking about some more definitive or useful biomarkers to help us decide how to treat patients in our clinic. Because I think that we are going to have a real problem. I mean, it's a good problem to have that we have too many drugs, but it's going to be a real concern. How do you decide whether or not to start somebody on Ruxo by itself or Ruxo in combination with other drugs?
You bring up a good point that a lot of things have been investigated. I hope whatever we study more and investigate and identify as being a useful biomarker is also something that can be easily done and not require repeated marrows, right? I think like things like NGS, which most people are doing now for patients with myelofibrosis, as we should. Blood counts, as you suggested, in some scenarios like anemia and momelotinib and thrombocytopenia and pacritinib and so forth, are certainly things that can be done easily and hence more useful biomarkers as compared to maybe things like myelofibrosis, which is always, a matter of controversy in the
Right.
field right now, and for the right reasons, given the fact, there's a lot of observer variability, there's a lot of sampling bias and so forth. Which, speaking of fibrosis, it makes me think about the phrase disease modifying therapy, which we have seem to use fairly vaguely right now. And I think I've asked this question earlier in the podcast as well. But what do you think? What would you want to be investigated in the context of disease modifying therapy for myelofibrosis?
Yeah, what a controversial term, huh? So, it's interesting. I think that disease modification can mean all sorts of things. What I want it to mean is what we get from transplant. I want to restore hematopoiesis and with that, improve blood counts and therefore obviate the need for extramedullary hematopoiesis and therefore, eliminate splenomegaly and symptoms. And that only transplant can do all of those things. And so I think that when we are trying to discuss disease modification right now, I kind of see it like in CML before the era of TKIs, where, you're discussing like, oh, does it matter if you have a 1 log difference or 2 log differences in your BCR-ABL? Whereas now we're like, I mean, who cares about that? You're just going to get to major molecular remission and maybe complete molecular remission. And so hopefully we'll get to have a biomarker like the BCR-ABL that you can just measure like exactly like you said from the blood, and that correlates with progression-free survival and overall survival benefit, which is really the standard for every disease except for MF, because I think it's just been harder to find that magic biomarker.
Absolutely. And this makes me think about some of the ongoing clinical trials trying to target mutant CALR. Conceptually, they
That's right.
appear to follow that analogy of CML that you were just giving. What do you think about those real targeted strategies which are investigational right now? How do you see they may hold their promise?
Yeah, I agree with you. I think it's super exciting to start seeing this like next generation of therapeutics, both monoclonal antibodies or even bispecifics or potentially CAR T cells targeting CALR, as well as several different JAK2 specific inhibitors. I hope that that is the beginning of a new, really targeted era in the therapeutics of myelofibrosis, where we really are doing all the things that I was mentioning before as what I consider to be disease modification with improvement in blood counts and reduction in fibrosis and reduction in spleen in a really objectively measurable way as opposed to these, subjective definitions that we have to come up with.
Absolutely. Yeah. We think about sort of these advancements and we think about a new generation, hopefully, or the new sort of category of medications. We have JAK inhibitors, we have drugs targeting non-directly JAK-STAT pathway, and hopefully now we'll see some of these immunotherapy-like agents, and at least in the pipeline under investigations. As we think about these different types of treatments, and as you were mentioning, the endpoints that we use, revolving around spleen and symptoms, I hear less discussion about supportive care in the context of MPNs and myelofibrosis. How do you incorporate that, or how would you like to see that incorporated in the studies as investigators think about their studies?
Yeah, that's a great question. So I think, MPNs really started out as being, I think, model diseases where, we had our first drug approved based on PROs, based on the MPN symptom assessment form and how patients respond to a therapy and, subjective improvements in symptoms and quality of life. But I do wonder if that's sufficient and if that's enough for our newer therapeutics, and if we need, to measure symptoms in a different way, or if we need to recognize that, some therapeutics are going to improve quality of life by improving symptoms immediately, and maybe some others are going to eventually improve symptoms, but they may take longer. Like, for example, going back to transplant, if you were to do PROs on transplant patients on day 30, they definitely feel much worse than they did maybe a few months before. So I think that MPNs are diseases that by definition require the PROs be included in clinical trial design, and I think that, the MPN symptom assessment form is definitely a useful tool that can quickly assess symptoms for patients with MPNs, but I think that there's many other symptoms that are perhaps not captured by the MPN staff, and certainly the investigators that we all know and respect that came up with this included these symptoms in that questionnaire because those are the ones that were the most common, and so that's why, of course, they were included. But for example, I find that, for some patient groups, like, there's some symptoms, like, for example, headaches that seem to be so incredibly prevalent, and they're not part of the symptom assessment form. I'm not a PRO investigator myself, but I do think that we need to partner with investigators that do have this expertise to include it in our clinical trials, because certainly before we can cure these diseases, helping to have our patients have improved quality of life is really important, and being able to really objectively measure that is so important too. I think that you may find this too, Dr. Jane, but, when you're in clinic, you may do an NP and SAF on a patient one day and then do it another day, and those scores really don't correlate with each other at all, and they may not have anything to do with the fact that the MF is better or worse. It may have to do with untreated sleep apnea or depression or other things that are kind of fuzzy and can get incorporated into the NP and SAF too. So I think that continuing to improve how we measure symptoms and including that in our trials is really important.
Absolutely. There's certainly that element of subjectivity, which is what we were talking earlier about, the endpoint discussion as well, that these can be subjective, especially when they end up being deciding factors for drugs becoming available for patients versus not. For the last minute or two, if I could open the floor for you and perhaps ask you what else in your mind would be something that you would like for maybe junior investigators to think about, or what future investigations you'd like to see in the field of myelofibrosis or MPNs in general, that you think are missing, and would like someone to focus on that. And then we can obviously partner that person with you to lead that study.
That sounds great. I think there's been tremendous growth in MPNs, and it's so exciting to see, how many drugs we have available in clinical practice, like you mentioned, with 4 available JAK inhibitors and multiple promising agents in development. What I'd like to see for the next couple of years of investigation and for the next round of clinical trials is really some innovation in a variety of different ways. I think the first is, can we identify therapeutics that we can utilize to treat patients earlier on, even, for example, when they have polycythemia vera and essential thrombocythemia, and preventing those patients from progressing to a disease that is as difficult as myelofibrosis. The other thing that I would really like to see is along the lines of endpoints like we were discussing, has to do as well with the inclusion of patients into trial that really represents the patients that we take care of. so that we can really ensure that we are treating the patients that need the help, and that we are learning from these trials what we intend to. And what I mean by that is, if we're only including patients that have good blood counts and have, no medical issues, and et cetera, then sometimes we really are missing out on treating patients that really require therapeutics much more. And so I think that having trials that really are willing to take some risk by including these high risk patients would, I think, potentially allow us to also have endpoints like progression free survival and overall survival in our trials. And I think that that could really help to move the field forward, as opposed to just focusing on including patients that are kind of low risk ish, and making sure that we can improve their spleen volume or their symptoms. So I really would like to see more from the endpoints and the patients that are included in these trials.
Absolutely agree, and that's certainly the theme that we've sort of that people have reflected on in the podcast, and it seems like all of us share the pain of needing or wanting and hoping better outcomes in terms of study endpoints. All right, with that, we'll conclude. This was, as I said earlier, this was a concluding episode of our podcast series. I hope our viewers have enjoyed. We thank all our guests. Thank you, Dr. Hobbs. This was an exciting discussion, learned a lot, and hope to see you soon.
Thank you so much for inviting me.
Thanks for listening to Medscape's In Discussion Myelofibrosis podcast series with our host, Dr. Tania Jain. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on myelofibrosis.